Thank you so much.
Thanks in the first part. And then we will now switch to another symposia on management of spinal cord injury. Dr. Sergio Salvador will be the moderator. I think Dr. Jesus will not join us. Yes, Sergio, you can start
Good
it now.
Good afternoon, where I am. Morning, good evening, depending on where you are. Thank you, Professor Zele, for organizing this symposium, this 8th symposium on the on management of spinal cord injury. So we will start with Professor Andres Rubiano, speaking on early care and transport. Professor Andres.
No. Oh.
Yeah.
Hi, Professor Salvador. How are you? Okay.
Hi, welcome.
Hi, Professor. Thank you so much. I'm gonna share my screen.
Yeah, please.
Okay.
We have 15 minutes for talks and then discussion.
Okay. Okay, thank you so much for the invitation. We are going to speak about care and transport of spinal cord injury patients, very focused on the management. So it's no conflict of interest. We are part of the NIHR Global Health Research Groups on acquired brain injury, brain and spine injuries. We are going to start with the knowledge of the burden of disease. This is the most study of the global burden of disease, showing how injuries that are in the green box, in the boxes in the bottom of the slide, is increasing, especially in young population. In the middle, we have the amount of diseases between 5 and 14 years old, and then 15 to years old. So we see how the green boxes are increasing. Talking about spinal cord injury, there is a huge evolution of the problem. In the last 30 years, it has increased a lot. Males and the elderly more affected than females and individuals, and the socio-demographic is correlated directly with the spinal cord injury incidence. So this is also associated that most LMICs does not have specific registries to report the condition. So it's regularly more reported in areas have more resources. Talking about pre-hospital and early care, we have several set of guideline consensus and recommendations. We're going to briefly mentioning that since 2010, there have been many systematic reviews talking specific about these specific topics. And also, we have in 2012 the ENS program from the Neurocritical Care Society with a specific recommendation for emergency management of traumatic spine injury. We have the CNS WFNS guidelines that were published in 2013. We have some recommendations regarding pre-hospital spinal immobilization, transportation, clinical assessment, radiographic assessment, and medical treatment. We evolve with a more set of guidelines. We have the early management recommendations for the World Federation Spinal Committee group. Then we have the clinical practice guide, specifically talking about the use of methylprednisolone that was published in 2017 also. Then we have in 2023 the best practice guideline of the American College of Surgeons related to spine injury. More recently, we have the AO clinical practice guide for the management of patients with spinal cord injury published in 2024. One group that was published, we recently published this set clinical recommendations consensus for patients when they have spinal cord injury and initially they have polytrauma. This was endorsed by the World Journal Association of Emergency Surgery. So in the middle of any of these different set of guidelines and recommendations, we are going to briefly about what is the actual status of the initial management since the pre-hospital transport and also in the emergency care room. We are know about the pathology of spinal cord injury, many of different mechanisms and how have been identified into the molecular profile that has been associated with some biomarkers that identify different stages, including blood-brain barrier leakage, the microglia damage, the infiltrating immune cells process, angiogenesis, gliosis, sprouting, and neurogenesis that comes from hours to months. So of these have been analyzed in depth in many review articles. So for the hospital care perspective, we have three main points that still are very valuable. We need to teach these teams how to do early clinical recognition and also use the effective immobilization criteria. So we are sure that we don't need to put cervical collars on all patients. Also, we to do a lot of emphasis regarding management of hypoxia and hypotension. Definitely need to get early transport to the nearest center with capabilities, including radiology, neurosurgery, and ICU. So since the 2013 CNS WFNS clinical practice guidelines, many of these recommendations have been performed, specifically about how to do immobilization. Definitely patients who are awake, alert, and not intoxicated, who are without neck pain or tenderness, who do not have any abnormal motor or sensory examination, and who do not have any significant associated injury, do not need a specific immobilization. A combination of rigid collar and the backboard with maybe supportive blocks is the main strategy when we decide to immobilize the patient. And we need to transport the patient as soon as possible with the center with better capacity. I addition here one of the recommendations that have been also transversal in many of the guidelines and consensus is the ASIA scale is the preferred clinical evaluation tool for acute neurological assessment in these patients. So we definitely need to also promote between the pre-hospital providers to teach them how to use the ASIA scale. Moving to the emergency room, we have some of the recommendations of the World Society of Emergency Surgery that I just briefly mentioned. We have the algorithm that they published. We were very supportive of highlighting that patients that have polytrauma and also spinal cord injury need to have an appropriate aggressive resuscitation since the beginning. So we manage all these patients with several of these thresholds that have been mentioned here in the consensus. There are around 17 or 19 recommendations that focus in many of these aspects. What are the best hemoglobin criteria, respiratory and blood arterial blood gases criteria, coagulopathy profile, also some of the variables for mid-arterial pressure, and how to use some different tests to evaluate the bleeding conditions in these patients. Also, the emergency neurological life support spinal cord injury section do specific recommendations about when to intubate these patients, when we have obvious respiratory distress or dyspnea, when we have complaint of inability to catch the breath, inability to hold the breath for 12 seconds, when vital capacity is reduced less than 10 milligrams per kilogram. So many of these aspects needs to be taken into consideration for the aggressive initial intubation of these patients. We also highlight here that has been addressed by the 2013 guidelines, the World Federation of Neurosurgical Society Spine Committee recommendations in 2017, and the American College of Surgeons Spinal Cord Injury Best Practice recommendation from 2023 about the use of the ASIA scale and the ASIA score in order to evaluate appropriate these patients. So related that neurological examinations in the emergency room, we already mentioned about the American Spinal Injury Association international standards that need to be taken into account. There are also some mentions about the spinal cord independence measure as the preferred functional outcome assessment tool. It has been also endorsed by the 2013 guidelines, the 2017 World Federation recommendations, and the 2023 American College of Surgeons best practice recommendations. Additionally, we have some set of recommendations regarding initial imaging. Definitely the CT is the standard of care in centers that do not have too much resources. Even if there is not CT available, we can use X-rays, but X-rays are not the first option, and these need to be highlighted. And definitely, the MRI is the only study that can allow us to see the content of the intraspinal canal. So all these need to be very well established. Is endorsed by the 2013 guidelines, the 2023 best practice recommendations of the American College of Surgeons. Regarding the instability hemodynamic management, the recent AO spine guideline has been very supportive of maintain a specific threshold of blood pressure. In this case, the recommendation is to manage at least a mean arterial pressure of 80 millimeters of mercury, but not higher than 90 to 95. And when you talk about how to do it, there are some specific sort of discussions regarding which medications are going to use, especially for patients that have spinal shock and also neurogenic shock. So there have been some recommendations related to norepinephrine and also inotropic and inotropic medications, according to the recommendations of the World Federation Spine Committee in 2017. Additionally, this same set of recommendations established that surgery within the first 8 hours should be performed in most of the cases. If feasible, these patients need to be treated in a specialized level 1 neurotrauma center, as mentioned before, for the transport patients to arrive to center that neurosurgery availability, imaging availability, and also ICU availability. Regarding the choice of vasopressors or inotropes, the recent AO spine guidelines does not do a specific drug recommendation. They mentioned that the choice of vasopressor or inotrope is dependent on several patient factors, including the presence of a central line, concurrent cardiopulmonary dysfunction, and comorbidities. The decompressive surgery has been recommended also by the AO recent spine guidelines 2024 in the last 24 hours, in the first 24 hours. The best practice recommendations of the American College of Surgeons also highlight the possibility of, since the emergency room start evaluating the patient with the AO spine trauma classification, all these different set of classifications that we already know very well. They are easy to use, comprehensive, and address some shortcomings of the SLIC and TLIC systems. Regarding pharmacological management, the 2013, the 2023, and the 2024 consensus guidelines have in common that they do not recommend the use of methylprednisolone, but they also highlight that there is no other potential therapeutic agent that have demonstrated some efficacy for motor recovery or neuroprotections. As we mentioned before, we have very specific practice guideline in 2017, led by Professor Felix, regarding some more insights about the use of methylprednisolone. They definitely do not recommend to use a 24-hour infusion or high dose of methylprednisolone to other patients who present after 8 hours. They left a very weak suggestion regarding the option of using in the first 8 hours. And definitely, they do not support the use of 48 hours infusion in patients. Before finish, just want to highlight some of the work that we have been doing regarding how to implement many of these different set of recommendations and guidelines, specifically in areas that have too many resources. We have been doing a lot of surveys in different regions of the world. There is one of the more recent one with 1,145 participants. If we go worldwide and mention how, if people is familiar with these guidelines, definitely, specifically neurosurgeons are more aware, also neurosurgical trainees, but not really orthopedic surgeons. And if we have the blue bar, that is all the specialties together, the World Federation of Neurosurgical Society recommendation for 2017 is only in the knowledge of 50% of many of these people. The WFNS CNS guidelines in less than 30%. The NICE guidelines of the British government in less than 25%. Other guidelines like the AO guidelines in less than 10 or 15%. So one thing that we need to know is that many of these guidelines are there, but many of the people that is taking care of the patient, especially in LMIs, do not know that set of guidelines. So we need to do a better job in order to spreading the content of these guidelines worldwide. And also, we recently do an analysis also in the regions of the world related to some of the recommendations, and we found the same trend that especially areas like Africa, Latin America, South America, many of these recommendations are not applied to or applied to many of the patients in different regions of the world. We specifically asked about arriving to facility with cervical covers, receive CT for cervical spine diagnosis, use of 3-view radiographic assessment if CT is unavailable, the use of corticosteroids, the maintaining of the mean arterial pressure, and the early surgical management, have a wide variation according to the region of the world. Was another survey that we did regarding early care. In many regions, especially in more low-income settings, there are no hospital systems available, so many people is not managed according to any of the recommendations because is not their EMS management. For cervical restriction, you see the small map. Green are areas where they apply the recommendation. Red and yellow are areas that they do not apply the recommendation, only occasionally. We also have the initial imaging cost. You see that in many regions of the world, especially Africa, Southeast Asia, and some areas of Latin America, people need to pay for the initial imaging. So this generates important restriction of availability for many of these recommendations in many of these areas. And the last survey that we did was related to ICU management and early surgery. So in many regions still, if you see the more low-income settings that are under the word A here, at least 80% of the countries do not have immediate ICU available for patients, if they have been operated or not. So many of these patients are returned to general wards and not to ICU for managing all these recommendations from the guidelines. And when we speak about timing to surgery, you can see in the map many areas that have a lot of red. That means that patients do not have access to surgery in the last 48 hours. And also, if you see many of the costs, the initial surgery need to be managed directly by pocket expense for the population. Also, rehabilitation is not always available. Many of the rehabilitation for these patients is performed at home. I just want to mention that because of many of these variations and heterogeneity, what we've been working is on the concept of bootstrap spine. We're all familiar with the concept that we proposed regarding bootstrap traumatic brain injury that is beyond one option for treatment of these conditions. So we just recently finished. We're going to work in the final draft of the document. Because when we in many of these regions of the world, if you talk, for example, about hospital care, you can have hospital care of very low resources, some sort of resources of all the resources. You can see this the scheme here with the blocks. Green blocks are centers that have all the resources. Centers are centers that do have all resources. Yellow centers are centers that have some sort of the resources. Then you move the patient to a facility in the emergency room that either can have access to early image, like the gray box, or centers that do not have early image, either low conditions, middle conditions, or high conditions resources. And then you can move centers that have immediate spinal surgery availability, either by a neurosurgeon or either by an orthopedic surgeon, or centers that do not have early access neurosurgery or orthopedic surgery. They only have sometimes general surgery care. And then you can have centers that have operative ICU care availability, or centers that do not have post-operative ICU care availability. So we need to set a specific guidelines or recommendations for each of these different set of settings. And what we did in the last World Federation Neurosurgical Society Congress in Bogota was specifically doing this, and we are going to publish soon all these set sort of recommendations. Also, to remember that with the global Neuro Trauma Research Group and also the Acquired Brain and Injuries Research Group. We have been doing this global neurotrauma outcome study. The University of Cambridge is there available for people that want to register. It's just a snapshot of how are the outcomes of these patients correlate to the initial management in different regions of the world. Actually, there are 220 hospitals entering data in 54 countries with more than 848 collaborators, and this is totally open to the community worldwide. So thank you so much. Many of these issues are part of what we are teaching and doing with our fellows in our neurotrauma fellowship program in Colombia. So this is something that is really important and need to be connected with the next stages of care. We are mentioned many of these discussions here. So thank you so much. And these are the centers that we are doing many of work and with our local research center, Meditech Foundation in Colombia. Thank you.
Thank you, Professor Rubiano. Excellent presentation. We proceed with Professor John Oma.